Morning, everybody. Can't hear you. Good morning. Are we all? Good. It's great to be fully dressed again, isn't it? Anyway, so firstly, can I just echo Paul's words of acknowledgement and sincere thanks to all the staff, including yourselves, who have battled COVID and the cyber attack over the last couple of years. That's no mean feat, so we just need to acknowledge that. The theme of the conference today is activity-based funding, the route to value, efficiency and quality. I'd like to focus on just one of those words, the word quality. I think that can fully address all of the issues around value and efficiency, and as Paul said, make it relevant hopefully to what we do every day and what all the teams and the services do every day. I think we can use value as our overall guide, and that in doing so we can deal with those other issues. To be a little bit more specific, I think we can show a clear link between quality, for example, as represented by the Institute of Medicine's 6 aims for improvement, value, as represented by our colleagues in DEEPR's Value for Money evaluation framework in 2007, and even the triple aim set out by the Institute for Healthcare Improvement. And the key thing is, the work you do, I believe, is directly linked to those objectives, directly linked to driving value for services and service users. So, the Institute of Medicine seminal report, Crossing the Quality Chasm, a new health system for 21st century, that's over 30 years old. It described the healthcare system as poorly organised, or which was poorly organised, that was overly complex, that was driven by multiple handoff points that slowed it down and reduced safety, and that also had cumbersome processes, resource waste, and a version of what we would call today the postcode lottery, in terms of variable service coverage and availability. Now, that was describing the American healthcare system over 30 years ago. Unfortunately, that report is very much relevant to many healthcare systems in the Western world, including parts of the Irish healthcare system, as acknowledged in the Care report. That Crossing the Chasm report talks about 6 aims for improvement. 1, provide safe care. In other words, do no harm. 2, provide effective care. That is evidence-based care, and only if it's likely to actually benefit the patient or the service user. 3, provide efficient care. So avoid waste, including waste of time, both the staff and the patient or the service user. 4, provide timely care. People need to access it when they need it. So it reduces waits and harmful delays. 5, care needs to be patient-centred. So take account of the patient's preferences and their own values. And 6, care should be equitable. So what does that mean? Quality and access to care should be constant, regardless of socioeconomic status, gender, geography, etc. So I think we could probably agree these 6 aims for improvement are in effect descriptors as to what could be the characteristics of a high-quality healthcare system. And I think that quality definition or characteristics easily map onto what our colleagues in DEEPR would refer to as value, or value for money. And sometimes when we say value for money, people kind of go, oh, it's nothing to do with services. But if we talk about quality, it very much is. So DEEPR talks about a program logic model. They talk about inputs, staff, activities those inputs allow us to carry out, outputs, treatments, and outcomes, short-term results, long-term impacts. Okay. Within their evaluation framework, they talk about economy and efficiency, but they also talk about timeliness, quality, and the cost of outputs. So we all know that efficiency is in effect, we provide the lowest practical ratio of inputs to outputs, consistent with providing quality care. But before you even consider efficiency, it must be effective. It must be delivering on the objectives, and therefore it must be of quality. And it goes on to economy. But that's their view of overall value. And it links exactly, I believe, to those 6 aims for improvement, which are really descriptors of quality. And it's only a small jump then to the triple aim. Aim 1, care, improve the individual experience of care. 2, health, improve the health of the population. And 3, cost. And cost is not about reducing the investment in healthcare. It's about reducing the cost per capita of care for the population. In other words, deliver more of what you have. Get the best out of what you can. And again, the work you do is directly relevant to that. So I think in terms of our theme for today, activity-based funding is an important part of the route towards both quality and, in effect, as we often would say, there is no value without quality. not because they're mutually or aren't mutually exclusive, because in effect they're one and the same thing. So, if we move on, as called out in Sláintecare, ABF is fully part of our plans, including our plans to establish regional healthcare organisations. As well as activity-based funding, Sláintecare also calls out population-based resource allocation. And I know some people have concerns that the population-based resource allocation might in some way replace or diminish activity-based funding. This is not the case. Both, i.e. ABF and population-based resource allocation, are already important parts of our implementation planning around regional healthcare areas. They are complementary. To be clear and specific, population-based resource allocation addresses, via planning and allocation of funding, the equalisation of healthcare resources by geographic area over time, taking account of whatever factors are agreed to feed into that equalisation model: age, gender, morbidity, rurality, disability, deprivation, etc. But it deals with the allocation rather than the payment of funding. So it determines the level of funding for a geographic area. It doesn't determine the means by which that funding will be transferred to the provider. Activity-based funding does that. So population-based funding needs payment methods, and activity-based funding is one of 8 key payment methods, and most systems rely on more than one of those methods. So, as I said, the two will and must live and operate effectively together. So, some other key messages, just moving on. ABF is alive and well. Yes, we have some setbacks because of COVID. We've had to return to block funding. We know that, as have other jurisdictions around the world. But the outputs from ABF have been used extensively during the pandemic, despite the fact that we couldn't use it for funding or payment purposes. We've used ABF to set National Service Plan activity targets. We've used it to benchmark private hospital costings against public costings. We've used relevant cost per bed day to fund the different type of beds, new beds, the big investment in acute ICU beds and other beds. We've used it as part of our transitions in terms of Safety Net 1. We've used it to code private hospital activity, and we've used it to train coding staff. So ABF is with us. ABF is important today. ABF is going to continue and will become more important as we proceed. And we expect in 2024 we will return to using ABF as a method for funding, for actually making payments. So we would urge hospitals to make sure they continue to do everything they can to submit their costing and their activity data as normal. We will continue to invest in ABF, as we have done. We expect to invest more. We do expect every hospital, in putting together any ABF resourcing plans, to be able to demonstrate that all the resource that we've put into ABF in recent years is actually in place and delivering what it's meant to deliver under ABF. And we're also investing centrally around community costing, because ABF has a role beyond hospitals. So in conclusion, I suppose a couple of points. ABF, as I said, is important now. It'll become more important over the next few years for both community and hospital planning and management as we move to more integrated care supported by the implementation of regional healthcare organisations. And in simple terms, the more we can demonstrate that we're providing good quality services at the lowest level of cost that is consistent with that quality, the easier it is for us to maintain and secure the necessary investment in our services. As Paul said, there is no black hole. ABF really helps us to demonstrate that. And again, the work that you do is directly relevant to that. It's directly relevant to the key part of improving our services over the coming years. So thank you for the work you've done to date. I look forward to us driving forward with the implementation of ABF, and I hope you have a very interesting and enjoyable conference. Thank you very much.